ma'am. Good evening, ladies and gentlemen. My name is Ashwin. On behalf of Brinton Pharmaceuticals, I welcome you all for this webinar of today, that is Diarrhea in Children, Role of Probiotics, Confusion to Conviction. For this webinar, we have eminent pediatricians from across India with us today. Our chief moderator for today's webinar is Dr. Malathi Satya Sekran. She is having more than 30 years of experience. She is an alumni of Madras Medical College and completed her DM in 1986 in gastroenterology. And her area of interest is in the diagnosis, treatment, and care of newborns and children with issues related to GI tract. Our panelists for today is Dr. Shrikant KP and Dr. Nishant Wadhwa. Dr. Shrikant KP is an alumni of PGI Chandigarh. Dr. Shrikant also undergone training in pediatric liver transplant from Cincinnati Children's Hospital, Ohio, USA, and Institute of Liver and Biliary Sciences, New Delhi. Dr. Nishant Wadhwa completed his PG from Kalavati Saran Children's Hospital and fellowship in pediatric gastroenterology and hepatology from AIIMS, New Delhi. He has successfully done more than 100 pediatric liver transplants. He has published he's executive of 10 years. So on behalf of Brinton, I welcome you all moderators and panelists. Now I request Director of Brinton Pharmaceuticals, Mr. Vijay Christopher.
Okay, thanks.
Please address the gathering.
Thank you, Dr. Ashwin. As they say, the man built a better mousetrap, the nature built a better mouse. This war of our mankind against the virus has been going on for many centuries. I'm sure and pray to God that he should be with us this time also and help us win this battle against COVID-19. Good evening, respected members of the medical fraternity. I am Vijay Christopher from Team Brinton. At the outset, I would like to pay my huge respects and regards to all of you, the COVID warriors, who are relentlessly working and protecting us while we are staying safe indoors. Once again, accept our huge respects and appreciation to all of you. Brinton is very proud and honored to host today's webinar, the topic being diarrhea in children, role of probiotics, confusion or conviction. I'm sure at the end of this webinar, people would move from confusion to conviction. Today, we have galaxy of eminent stalwarts and international KOLs amongst us. It's my proud privilege to welcome the moderator for this evening, respected Dr. Malathi Satya Sekran from Chennai, whom I know personally for the last 2 decades, and she also happens to be the pediatrician of my son. And distinguished panelist, respected Dr. Nishant Wadhwa from New Delhi, and respected Dr. Shrikant from Bangalore. Now over to Dr. Ashwin.
Thank you so much, sir. Now I request Dr. Malathi to please take over the session.
Yeah, good evening. It is indeed a great privilege and joy to be here this evening, though it is a little sultry over here. I think this academic session will make us more cool also. And I would like to thank Mr. Vijay, Mr. Datta, Dr. Ashwin for that introduction. And we realize that this is definitely a very difficult period for us, this Corona war. And we also remember the first line warriors. So during this lockdown, let us not break down. Let us not look down at those who, the underprivileged and less privileged. But today we have all come down to share the knowledge, because knowledge shared is knowledge gained. I would just like to read this nice poem, which we always think, this too shall pass. So as Mr. Vijay was saying, Corona war will also pass. So when things are bad, remember it won't always be this way. Take one day at a time. When things are good, remember it won't always be the way. Enjoy every great moment. And I think today we will enjoy this great moment when we are going to share some thoughts about diarrhea in children, role of probiotics, confusion to conviction. And as the panelists have already been introduced, I would like to reassure you that we will leave the listeners with some clarity of thought They will not go out with confusion, but there will be some conviction in their minds when, where, how, why to choose the probiotics. Aarti, may I have the first slide, please? Yeah, so as I was telling you, this today the talk is diarrheal disease, and we all know diarrheal disease can present with either as acute, persistent when it lasts for 14 days, acute onset, and chronic when it is more than 14 days, but it's of insidious onset. But the role of probiotics has mostly studied in the acute type of diarrhea, but also in others. And even we see in 2020 that there is some confusion, and we have to now take the listeners and the panelists to this, that there is some conviction also. So, what is this connection between probiotics and diarrhea? What is this connection between probiotics and diarrhea? Why should we ever think about probiotics in diarrhea? Next slide. The whole concept of this is because of this little world, not little world, the big world which is living inside our body. That is the microbiota. Next slide. We realize that we have a big set of organisms, huge set, where the microbes even outnumber the human cells in the ratio of 10 is to 1. And if you lay them one behind the other, end to end, they will encircle the earth 2.5 times. And therefore, we realize man harbors inside his body without our knowledge. Apart from our body cells, we have organisms and other microbial cells, hundreds and trillions of microbial cells. Next slide. What do these microbes do inside our body? Next slide. And these microbiota change according to whether you're breastfed or formula fed, vaginal and cesarean. And as you grow, next slide, it also changes with the age of the individual. Next slide. Next slide. And those who are born either by term and who are breastfed will have the bifidobacteria. And as I was telling you, it will change with age. So as you grow, you will find that you start changing from bifidobacter to firmicutes. Next slide, which is mainly formed by the lactobacillus. And then you have. So you just remember that there are millions and trillions of organisms inside our body in the GI tract. And the lactobacillus forms a big bulk of them, and the bifidobacterium also. And they change with the type of birth, with the type of breast milk or artificial milk, and also with age. Next slide. And what do they do inside our body? The light blue circle shows that it means its very important role is the integrity of the gut barrier. So it is very important to maintain this, reduces inflammation, maintains tight junction. In addition, there is immunomodulation, antimicrobial effect, nutrient metabolism, and also it is responsible for some zoonotic metabolism. So mainly the integrity of the gut barrier, the immunomodulation. So these organisms are inside the GI tract and they are protecting the GI tract. They are decreasing the inflammation. They are also acting as an immune modulation activity. Next slide. So during diarrhea, what happens? We know the pathogenesis of diarrhea. Either there is increased secretion, and that is why we sometimes give anti-secretory drugs. There is decreased absorption, and therefore we give ORS. There's an altered permeability, and therefore we give zinc. But very important, one more pathogenesis is this alteration of this microflora or this microbiome, which is inside the GI tract, is altered during diarrhea. So this mechanism, how can we change that? How can we help that? If something is gone, can we replace some other organism or the same organism and see that the gut starts functioning? Next slide. And that is how the problem of whether to give a probiotic or an antibiotic. And we all know that there are so many side effects of antibiotics. Antibiotics themselves can cause diarrhea. Antibiotics can decrease the absorption of many institutions. They can have antibiotic associated diarrhea, and it can also injure the villi. So therefore, next slide, probiotics for centuries have been used And that is the concept of using the bugs itself as drugs. Next slide. So now we know that yes, there are microorganisms inside the gut. They are doing some good job, and in diarrhea, this gets altered. And therefore, the concept of using probiotics in diarrhea is whether we can give a probiotic and bring back the good flora inside the gut. So I would like Nishant to tell me what are probiotics, and you can tell the listeners what are prebiotics and what are symbiotics, so that they get a little more clarity of why we use probiotics in diarrhea. Next slide.
And the probiotics, thank you, ma'am. Probiotics are viable, defined microorganisms in sufficient numbers. And these three defining criteria for probiotics are important: viability, defined numbers, and definition of the microorganisms, the particular genus flora, which alter the microflora of the compartment of an host so as to confer a health benefit. So probiotics are these live organisms, which when ingested confer a health benefit. But when we look at the prebiotic, and they are often used along with probiotics, they are non-digestible food ingredients which have beneficial effects on the host by selectively stimulating the growth and activity of one or limited number of bacteria. So these prebiotics can be considered as the food for these bacteria which are used as probiotics. These can be fructans, these can be oligosaccharides, these can be galacto-oligosaccharides like present in breast milk, or are fruits and certain vegetables, which are, for example, bananas, tomatoes, isabgula, and wheat. So these non-digestible foods, which are actually the food products for probiotics, help these bacteria grow. But when we talk about symbiotic, it's a combination of a pro and a prebiotic in such a manner that the prebiotic favors the selective probiotic compound, and this combination is known as symbiotic. For example, oligofructose along with bifidobacteria.
Thank you, I think, for clarifying it so well. So no one can deny the fact that probiotic is beneficial. Probiotic is necessary, and in sufficient numbers, it is useful. So I think that everyone agrees. And so when you give a probiotic, it alters the microflora in a compartment of the host. And that is what Dr. Nishant is saying. If you give a probiotic and put it into the GI tract, it will change for a beneficial effect only the compartment, the host flora. So let us see what Dr. Srikanth tells about the activity. What are the common probiotics available in the market, Srikanth? And what is its action of probiotics? We know they are beneficial, and we said that they do some job, but what do the probiotics do? We know the job of the microflora, but what do the probiotics do?
Yeah, thanks for these questions. So there are various probiotics available. So depending upon, as Dr. Nishant had highlighted, it depends on the strain, species, and also the quantity in which it is delivered. So most commonly used probiotic is, they're basically categorized into, classified into three categories. That is Lactobacillus group, Bifidobacterium group, and Streptococcus group among the bacteria. And there are few yeast and other organisms which are also used. So by far, Lactobacillus is the most commonly used. Among them, Lactobacillus rhamnosus and its subspecies, and Lactobacillus reuteri. These are the lactobacilli group which are used, and various Bifidobacterium group organisms are also used. And there is a combination of probiotics, that is something called BSL-3, which contains total 8 different strains of these probiotics, which once again comes from 4 lactobacilli, Bifidobacterium, that is 3 bacteria from Bifidobacteria group, and Streptococcus group. And interestingly, these are all non-sporing bacteria, and yeast, which comes as spore, that is Saccharomyces boulardii, which is almost like in many of the conditions, which is equivalent to the lactobacilli group as well. So these are the different probiotics which are available in the market. So next, moving on to the mechanism of action of probiotics. So it is not a simple drug which acts on one specific pathway. So it has multitude of actions at various levels in the GI tract. So one is it competes with the pathogenic organism for its nutrition and also for its niche in the GIT, and it inhibits growth of bacteria by secreting certain bactericidal components. It immunomodulates. So because of this, it has been used in so many inflammatory conditions such as IBD and IBS as well. And it has trophic effects on the intestinal tract. It increases the survivability of the crypt enterocytes. And also it helps in production of the short chain fatty acids in colon, which actually are the energy generator for colonocytes, and decreases gut permeability. So gut permeability is something which is one of the innate type of immunity which prevents translocation of the bacteria and other hazardous substance into the body. So this probiotics helps in reducing gut permeability, and also it ameliorates cancer condition. So it may cull so many adenocarcinomas, even though it cannot be used as a whole and soul agent for cancers, but in many of the studies it has been used as a adjunct along with anti-cancer medication. So it has a host of effects on the human body, rather than like viewing it as a simple drug which acts at one receptor. Yeah. Thank you, madam. I assume this is at least in a nutshell, we can put it as a mechanism of action for probiotics. But it is strain specific and dose dependent. So, every strain or at every dose, it may not give same results. So that's why there is some variability in the results which are seen in many trials. Yeah.
I think you have some pictures also, cartoons.
Yeah. This is just a cartoon representation of whatever I have highlighted earlier. So enhancing the epithelial barrier, production of antimicrobial, that is proteins against the microorganisms which are pathogenic, inhibiting the addition of the pathogenic bacteria, and many more. Yeah. Thank you.
So I think at every level it seems to be working.
Yes.
So I think the most important, it is good. It does a lot of jobs, but I think we have to be very sure it is strain specific. I think that is very, very important and dose dependent. We just can't use any probiotic for any problem. So I think that we should understand.
Yes.
I think of them, I think a lot of work has been done only on lactobacillus. Gigi, Dr. Srikanth and Nishant, I think will agree. Earlier, when we did not have this, we kept on talking about something we did not have. We said LGG was the best and it's not available. But now I think it's come into the market. Next slide. I think you have one more cartoon to show the complexity of the action.
It is just, I don't want to read through this slide. It is just shows the various crosstalk between immune cells inside the intestinal mucosa and gene modulation, like which finally results in anti-inflammatory and other beneficial effects on the human host. So that's what this cartoon
it's a beautiful slide showing various ways where the probiotic is working.
Yeah.
So the gut microbiome is also doing a very good job. Yes. And we realize that many diseases are now going to be related to alteration of the gut microbiome. And gut microbiome is one of the key factors for many diseases. A probiotic will also do, but only thing I think more work, more research needs to be played. Next slide. So now we'll come to two cases. Next slide. Very simple case scenarios for the listeners, which they will be seeing every day in and day out. Here's a 2-month-old baby, exclusive breastfed, watery stools 8 to 10 per day. Grandparents and parents very anxious. So they seem to be more anxious. It's just for 15 days. And it's an alert baby, active baby. The birth weight is quite good. From 2.8, it is now 3.6 kilos. The only finding is the perineal excoriation. Very bad looking excoriation. The whole, the gluteal and buttocks are red. The stool reducing substance is 2+. So we all straight away make a diagnosis. You don't have to do culture. You don't have to do anything. Just seeing the baby. Next slide. The diagnosis is what we call transient lactose intolerance, and probably it's the foremilk diarrhea, because we know the foremilk contains a lot of lactose and only the hind milk contains the fat. And so the baby sucks only at the foremilk, does not take the hind milk. And because it doesn't take the hind milk, satiety is not there. It keeps sucking, and the increased number of times it sucks is more, and the number of times it passes is more. And because lactose, once on digestion, becomes more acidic stool, it's mainly the acidic nature of the stool which causes this perineal excoriation. Next slide. And this concept, next slide. Next slide. Lactose intolerance and, no, previous slide. Lactose intolerance and probiotics. This has been our understanding from for a long time. That is, if you give curd, the child will tolerate better. One is because of the low lactose in it, and also because it contains the lactase producing bacteria known as Lactobacillus acidophilus. It was also found that when milk was, Bifidobacterium longum was added to milk, they had less flatulence, less hydrogen production. It was also found that Lactobacillus bulgaricus and Streptococcus thermophilus produce lactase enzyme. On the whole, we know probiotics definitely produce beta-galactosidase or lactase intracellularly that may assist in the digestion of lactose. So there is a role of probiotics when there is a lactose intolerance. This probably is the lactose intolerance we get after we take antibiotics or after you get diarrhea, a little bit of lactose intolerance where you have a low level of lactase enzyme. Next slide. But here we are talking about a transient lactose intolerance, and this was a study, a very good systematic review showing the effects of probiotics in lactose intolerance. And what they have found is after 15 clinical trials were included in the systematic review, and they studied 8 strains of probiotics. The results definitely shows that there is a positive relationship between probiotics and lactose intolerance. And of the 8 strains, Bifidobacter animalis was amongst the well researched. It's a very nice paper, but this was mainly used for the lactose intolerance, which is seen post-infective diarrhea state, that type of thing. Next slide. So I would like to ask Nishant, in this baby, a newborn baby who is taking exclusive breast milk, how will you manage? Do you think role of probiotics will be necessary in this baby? Comment on breast milk as a symbiotic.
Thank you, ma'am.
Next
Now,
slide.
the first case which we have just discussed is actually a case of a physiological, largely physiological lactose intolerance seen in the initial months after birth, because we know that the breast milk has the highest lactose content among mammalian milks, while the intestine is still in a stage of maturation and the lactase enzyme is still being matured in the enterocytes. So the only treatment required in this case is that the mother should be asked to, first of all, empty the breast completely and then shift to the other side. Or she can actually discard some amount of foremilk and predominantly feed the child hind milk, which would also result in satiety. There is really no role in an exclusively breastfed infant of any formulas whatsoever. This entity can be treated by physiological means. But when we do talk of primary lactose or secondary lactose intolerance, in fact, then definitely there is a role. But in breast milk per se is itself a symbiotic. A high lactose content in the breast milk, as I mentioned, promotes the growth of bifidobacteria, and which is a preferential substrate for bifidobacteria. Besides this, galacto-oligosaccharides, which I mentioned earlier, act as a prebiotic on which these bacteria act, and they proliferate in the gut of the newborn. And hence, breast milk per se is a symbiotic, and hence the role of continuing breastfeeding in these kids.
Yes, very good. Yeah. Next slide.
So, like I said, we should reassure the mother, ensure that the infant takes hind milk, and one of the essential practices would be that the mother should completely empty one breast before shifting the child to the other side. Because if she keeps on shifting, she would predominantly feed the child foremilk alone, leading to more diarrhea. Spacing out of feeds is another option which can be done. And like I mentioned, very occasionally, it may be necessary to supplement with non-lactose feeds, but this should be in really minuscule number of patients or children, I must say, infants. But there is really no role of any drugs whatsoever or probiotics which need to be given secondarily to these children. Just continuing breast milk and changing the method of feeding and explaining and reassuring the mother should be sufficient.
Thank you, Nishant, for clearly emphasizing that breast milk should be continued and that breast milk itself is a symbiotic. So the spacing, and it's all because of that core milk containing more lactose. I think it was very clear. I think the listeners also will now be sure what they have to do. Next slide. So now we come to another very common problem we see. I think let the participants just read this case scenario very slowly. It's a 5-month male infant with diarrhea since 30 days of life. That was from, it was a breast milk, exclusively breast milk baby. This is a different baby. This has yellow stools, blood is there, has been hospitalized twice, has received antibiotics, birth weight 3.2, now 4.3 kilos at 5 months. So, and there is a rash. The baby has been on supplemental top feed since birth, no breast milk since day 30 of life. That means there's been an introduction of another protein, milk protein. So there is some addition of milk protein. Next slide. And there's no breast milk from day 30 of life. So here it is more sick looking baby compared to the first case scenario. There's a rash on cheek and forearm. There's a mild perianal excoriation because of the acidic stool. Abdomen soft, liver 3 centimeters. So here there seems to be a temporal relationship between the symptoms and the introduction of a milk protein. And what is the milk protein which the baby gets at that age? It is only cow's milk protein. So with this rash, with a skin manifestation, a little bit of a colitis picture, not gaining weight, I think the first diagnosis which we would think of is slide. Next slide. A probable cow's milk protein allergy. Slide, I think it's hanging.
Yeah, it's hanging. Just give me a second.
Cow's milk, probable cow's milk protein allergy. We can think of other causes of colitis, but here I just want you to look at the presentation. Here there is a temporal relationship to the addition of cow's milk protein. There is a skin manifestation. There is a colitis. So the first one should be only a cow's milk protein allergy. It's a moderate severe because there is blood, there is failure to thrive. And here let us not think about the other causes of colitis. In our country, we do think of infective, but here we are very clear that this looks to have some allergic component in the mode of presentation. Next slide. So since we are sticking only to the probiotics and diarrhea, we are not going too deep into cow's milk protein allergy. I would like Srikanth now to say in lactose intolerance, Nishant was very clear, especially the physiological lactose intolerance, which is seen in the neonatal and early infancy, no role for antibiotics. This is also a young infant, Srikanth. What is the role of antibiotics in cow's milk protein allergy? That is not different. Try to diagnose whether it's some other form of colitis. We'll take it as CMPA. How will you manage this case? Do you think probiotics will play a role in this child, infant?
Yeah, thanks for those questions, ma'am. See, this is we are almost assuming it is a cow's milk protein allergy, and the history is very much consistent with this. So there is no role for antibiotics. Parallelly, as such, there is no role for probiotics as well. So the management includes just avoiding the whatever allergen is causing it. So here it is clear-cut cow's milk allergy. So cow's milk protein is the allergen. So we have to avoid it in whatever ways possible. If the baby is exclusively breastfed, then avoid all the dairy intake for the mother so that mother can continue breastfeeding. Or if the baby is top fed, then you have to replace those top feeds with hypoallergic or non-allergic formulas, which doesn't contain cow's milk allergy. So it is quite simple. So as such, there is no upfront evidence to start any probiotics which would help in either curing or preventing those things, even though there is some evidence recently about some of the probiotic components, but still it is in its infancy regarding the treatment option. So as of now, it is only avoidance of the cow's milk allergy, and it is not a very serious condition. Eventually, children would outgrow. By the age of 1 year, nearly 95% of the kids will outgrow of this allergy, and by 4, almost every kid will outgrow. Yeah. So this is one of the meta-analysis systematic review. So there was no earlier resolution of hematochezia. That's what the result says with this. This very recent systematic review of an RCT.
Yes, I think, and in this RCT also, they had low quality evidence, and the acquisition of tolerance, Srikanth, was at 36 months. And you yourself have said in children by tolerated as quickly as 18 months itself, 90%.
Yeah.
So we cannot take this study also. So LGG, maybe there are some studies for food allergy, but in cow's milk protein allergy, like you said, the best would be to avoid the allergen. So protein, and the next slide, I think you can say whether when you give extensively hydrolyzed formula or amino acid.
Yeah, this is like, once again, the exclusively breastfed child, stop dairy for the mother, or if it is not improving in that situation, secondarily, we can add hypoallergic formula. So if the symptoms are mild, we can try with extensively hydrolyzed formulas, which are short chain peptides will be there. And if it is severe, then amino acid based formulas are used. This is predominantly for less than 6 months age. And more than 6 months of age, parallelly, we can start other home-based non-allergic food items sequentially. So they need not be on formulas throughout their infancy. And as there is no role for probiotics.
Very important. I think, Srikanth, you have emphasized very clearly. See, that means don't start with amino acid for all babies with cow's milk protein allergy. One is the cost, the other one is they will stop it, and that taste is so bad, the child will not drink. So finally, you will come with malnutrition, and pocket also, there's a hole. So I think extensively hydrolyzed formula, make a proper diagnosis, but at present, there's no role for probiotics. Even if you give, it might just increase the tolerance, but that too by 36 months. That's what they could not show a difference between the 6th month and 12th month tolerance. So I think we'll just stop and see whether there are any questions, Aarti, till now, so that we can just take the next case quickly.
Yes, ma'am, there are questions. Is there any role of prebiotic in lactose intolerance?
Nishant, can you answer that? Role of prebiotics in lactose intolerance?
Yeah, like I said, in lactose intolerance, it is the bifidobacterium which do help, and any combinations with bifidobacterium might be useful. But in the present case scenario which we used, there was really no role of probiotics. The breast milk per se serves the prebiotics and helps heal the child.
Yes, I think that's what he said. If it is the one which we were discussing the case, we don't need. But I think Nishant has told you that if it's a secondary lactose intolerance, that time we were using this banana-rich food where the banana acts like a prebiotic. I think, Nishant, that's what they might have asked. And we also use a rice-based formula, which is also, I think, one of the ways to do it, adding a prebiotic because you get the other saccharides in that. I think main thing was the banana-rich based formula. Any other question, Aarti? So we can go to the most important case now.
Yes, from Dr. Vivek Mahajan. Are probiotics used for all types of diarrhea?
Well, now that's coming for case 3. Next one.
And how Lactobacillus rhamnosus GG is better than S. boulardii?
Okay, I think just keep that. So we'll go to case, I think we'll go to case 3, Aarti. Next slide. Okay. So now we come to case 3. So we've seen 2 case scenarios, very common. A temporary lactose intolerance in a newborn. It was a physiological. Nishant explained it so well. Srikanth explained the CMPA so well. So now we come to a very important case, which we see day in day in practice. It's an 8-month-old female infant, 2 days of watery diarrhea, 6 per day, no blood, no mucus, no past history of diarrhea. It's just an abrupt onset of diarrhea. There is fever and vomiting at the onset. The diet is exclusively breastfed till 6 months of age and was on rice dal. And I think at the time the mouthing has started, the baby has picked up something and the baby's now having come with diarrhea. Next slide. So this is the acute watery diarrhea we see day-to-day practice. There's no dehydration, but the mother is anxious. Otherwise, the investigations are normal. Next slide. So this you make a diagnosis of, next slide, acute watery diarrhea. To complete, you always say there's no dehydration, and always remember to look at the nutrition of the child. So the burden of diarrhea, we know even in India, it is still, diarrhea is very, very important. And this is the acute watery diarrhea, which we talk about, which is a very, very important cause of death worldwide, especially in India. Next slide. So we know that ORS and zinc have definitely changed our outlook. They have decreased the mortality, decreased hospitalization, especially ORS. And zinc has also helped in decreasing the number of more than 7 days diarrhea and also preventing persistent diarrhea. We know the etiology of acute diarrhea is majority, it is viral. And we realize that so we don't require much of antibiotics. There are some bacterial diarrhea and some where there is blood and mucus when we give antibiotics. So as in the pathogenesis, we use ORS, we use zinc, we use antibiotics for a very small group. Where will probiotics work? Next slide. So there's no clear-cut definition to find out whether this is bacterial or viral. And even in bacterial, I believe it is more the toxin causing diarrhea. So you may have little high fever, there may be an older child, but there are no clear-cut, and it's no use doing CRP or procalcitonin to differentiate between viral and bacterial. The dehydration is what we have to treat. The zinc has to be added, especially for both the watery diarrheas, whatever they may be. And let us now see whether probiotics will be useful. Next slide. Next slide. So I would like, Nishant, now you have given a very clear outline for transient lactose intolerance. Now, we all know the importance of ORS and zinc, Nishant, but do probiotics play a role in acute watery diarrhea? Do you want to add one more prescription in your thing? Is there a confusion its role? Any Indian data about what about the thing? Most of the data from the West might not, we cannot extrapolate it to India because our situation is different. Are there any Asian Pacific recommendations?
Thank you, ma'am. Yeah, we do know the importance of ORS and zinc, and there is no questioning the fact that these two entities are necessarily the backbone of therapy of acute watery diarrhea in any country. And needless to say, in our own country, they definitely form the backbone. And these are the pillars of therapy for acute watery diarrhea in India. But when we talk about probiotics in acute watery diarrhea, there has been a confusion regarding the mode of effect and the effect in the frequency of stool and the duration of diarrhea. And these two modes, and a lot of confusion has also gathered because of the variety of probiotics which have been studied. And largely in developed countries in the Western world, where different guidelines have emerged. And that probably was the reason for the confusion, because it has been found that even with the use of probiotics, the actual reduction in duration of diarrhea was not more than a day. But then now we have Indian data as well, and there have been Asian Pacific recommendations. When we look at the beneficial effects of probiotics in diarrhea, we find that they do help in reducing moderate reduction in duration of diarrhea. LGG has been found to be the most, Lactobacillus GG has been found to be most effective in a dose of more than 10 raised to power 10 colony forming units. And this dose and the strain specific effect is very important to understand in acute watery diarrhea. And it's effective only when administered early in the course of disease. And do we have studies from India? Yes, we do have a study from from West Bengal. Dr. Sutapa Ganguly had done a study where she found that LGG was effective in reduction of diarrhea, where the strain used was Lactobacillus GG itself. Now, there have been various studies as well, which have not been very supportive. And I must say that the number of studies supporting the cause of use of probiotics in diarrhea and the numbers again have been in equal numbers. And probably there have been proponents of both for and against the use of probiotics, because as we know that even in the studies where they have been found useful, the reduction in duration of diarrhea was not more than a day.
Next slide.
And So this was the study which was done by the Dr. Sutapa Gangli group in West Bengal, and the aim was to adjust the effective dose of Lactobacillus rhamnosus GG as a probiotic in acute watery diarrhea. And it was found that while both the doses, there are three groups of patients, one which received only ORS, the other which received ORS with LGG containing 10 raised to power 10 CFUs, and the third group which contained double the dose of LGG. So where 10 raised to power 10 CFUs were given twice a day for a period of 7 days. So the duration of diarrhea was definitely reduced as compared to the ORS group alone. And both the doses were equally effective in decreasing the frequency as well as the duration of diarrhea and reduction in the hospital stay in patients with acute watery diarrhea. So this particular study is from India itself and has found useful in the use of Lactobacillus rhamnosus GG.
Next slide.
If we look at the Asia Pacific guidelines, we do find that LGG and Saccharomyces boulardii CNCM strain I745 has been used as an adjunct to rehydration. I would like to just highlight that the guidelines which we have, you actually promulgate the use of probiotics as an adjunct to ORS and zinc. So the mainstay of therapy still continues to be ORS and zinc. And it is only in the third category that probiotics find a mention as helping in reduction of the duration of diarrhea. And they do find mention in the Asia Pacific guidelines which have been published in 2017.
Thank you, Nishant. I think Hania has done a lot of work, and she has definitely, even in 2005, recommended LGG for diarrhea. And because in the West, even one day, if, decreasing the duration of diarrhea for when both the parents are working, they find it a big useful. It's very useful for them because the child cannot be sent to the child care. The mother has to stay at home. So there, I think it was really a big beneficial thing for them. And so they did give a lot of importance for that. And I think it was extrapolated in this. And we have to give even in our country, but along with ORS and zinc, I think, but the duration of diarrhea is decreasing, not the frequency. I would like to ask Srikanth, so what are the ESPGHAN guidelines? Because I think all over the world, people will look at ESPGHAN guidelines. What do they say? Have they looked into this? Is it recommended for everyone? What is the confusion in its role? What is the conviction? So I would just like you to sum up that ESPGHAN guidelines, the recent ESPGHAN guidelines for probiotics in acute watery diarrhea.
Yeah,
Next slide.
Thanks, ma'am. Continuing with Nishant sir's discussion. So in 2017, that is the World Gastroenterology Organization, and ESPGHAN in 2014 recommended these two, that is LGG and Saccharomyces boulardii, as a third one of the option along with ORS and zinc. But this is once again all these strong evidence come from European Union, Dr. Hania's studies and various meta-analysis which she has performed subsequently. So ESPGHAN clearly recommends LGG or Saccharomyces boulardii for acute watery diarrhea. So as Dr. Nishant had highlighted, if it is started early in the course of disease, then definitely there is a benefit. But if you see the subgroup analysis, including various outcome measures, so it may not prove beneficial in certain outcome measures. So definitely the decreasing in the duration of diarrheal episodes is significant. So there is a 1 day reduction in the diarrhea in the treatment group, which has been given with these probiotics, but certain other parameters may not improve. So then there is a confusion. If you try to debate and dissect it in very much detail, so it may not favor certain aspects. And parallelly, Lactobacillus reuteri and other acidophilus, those has not surfaced as a therapeutic agents in this group based on the ESPGHAN recommendation. And if you ask me if there is, I think there is, this is a NEGM study recently. This is a huge number, nearly 1,000 participants. So this says that there is no difference in the outcome as compared to placebo. So this is the latest one, that is 2018. Probably there may be few more studies subsequently. Maybe we may see the meta-analysis. So here the problem with probiotics is it's a very complex drug.
I think this is the one which you were talking about.
Yes,
So
yes.
the previous one, the emoji was very sad, Srikanth, because everyone was feeling very bad when the report came.
Yeah.
But I think there was some back thing, they said this was not done properly and all that. But I think this Anya again went through all the RCTs and now they've given this report.
Yeah, that's what we were discussing before the beginning of this panel discussion also. So the effect of this probiotic depends on how it is manufactured and the temperature and so many things. So it can vary actually. So it is not a simple drug which has a receptor or some direct action. So probably that's why it is somewhat difficult to do a proper study having beneficial in all the outcome measures we intend to look at. But definitely, barring that one study, but all other studies for acute watery diarrhea, there is beneficial role of LGG. And if you see physiologically also, these probiotics has lot of good effects on the human gut. So taking all those things, I
think regarding the strain, we will say LGG is the best to reduce the duration. I think it is very important that the dose is very important. Srikanth and Nishant have said that more than 10 to the power of 10 colony. It's just not quarter sachet morning and then another quarter next day. It's not like that. Ensure that the amount you give is correct. Ensure that you start early in the diarrhea onset and then you continue for a minimum of 5 to 7 days if you want to know the effect. I think that is very, very important. I think Hania was also very clear saying that it seemed to be working better in European countries. Maybe because they store it also properly and they keep it well. And I think they would have given the correct dosage. In some places, they will buy one sachet and use it for 5 days. That's all there. So I think it's very, very important for the listeners to know what they are giving. So Lactobacillus GG or Lactobacillus rhamnosus GG is the one which works in acute watery diarrhea. The dose is very, very important. When to start is very important and the duration is very important. We'll just go to the next case and then we'll take up questions. I think there'll be many now. Next slide. So next slide. So this is another child has fever, cough, and they've given antibiotics because it had opacity right lower lobe and it develops loose stools. So here the doctor cannot stop the antibiotic, but the parents are now anxious because child has came with one problem, now it's got another problem. So they want to know what to do, whether to stop antibiotics, and we know the diagnosis is antibiotic associated diarrhea. This is a very common problem. Next slide. So Nishant, do you agree that this is antibiotic associated diarrhea? When do you say a child has antibiotic associated diarrhea? What are the role of probiotics? Conviction? Should we give probiotics to all children on antibiotics?
Yeah, thank you, ma'am. Yes, this indeed is an antibiotic associated diarrhea. Any diarrhea which occurs even up till 2 weeks following the beginning of antibiotic is considered as an antibiotic associated diarrhea of more than 3 stools per day for consecutively 2 days. And so the incidence is around 30%. And probiotics have definitely been studied in the prevention of antibiotic associated diarrhea in children, again by Hania and the JPGN publication in 2016. And the strains which have been studied and have been found really useful have been, again, Lactobacillus rhamnosus GG and Saccharomyces boulardii. And there has been strong recommendations for their use in prevention of antibiotic associated diarrhea. Having said that, there has been no role seen in the prevention of Clostridium difficile diarrhea. And the recommendations have been conditional, and there have been low quality of evidence in the usefulness of these strains in prevention of Clostridium difficile diarrhea. But when we now the probiotics need not be given to every child who is prescribed antibiotic. It may be prescribed where there has been a prolonged use of antibiotics or in hospitalized patients. And there are specific populations where the patients do have a history of antibiotic associated diarrhea in the past where they can be useful. Now, the starting time, the beginning time should ideally be within 48 hours of antibiotic administration, and they should be continued for 7 days after the antibiotic stoppage. And a minimum of 5 billion colony forming units per day should be administered. And there should preferably be a time gap of 2 hours between the antibiotic administration and the probiotic administration. So yes, there is definitely a role in the prevention of antibiotic-associated diarrhea. And the sooner the probiotic is started, the better is the effect. And again, Lactobacillus GG has been found to be useful and is recommended in various ASPGHAN recommendations as well.
Next slide. I think we have more or less given a very clear thing for antibiotic-associated diarrhea. Are there questions, Aarti? We'll just take 4 or 5 because we have...
Yes, ma'am.
Yes.
DP, sir?
Any questions?
Madam, there are some questions, and Dr. B.S. Sankaranaran has also joined us, and
Yes.
he has made a comment on the role of lactase enzyme in severe excoriated liberated extensive seen in the picture when Dr. Nishant presentation doesn't
But
improve.
today our discussion is mainly on probiotics, so we didn't go too much into detail. But lactase enzyme for the secondary lactose intolerance can be given. It is available thing, but it's such a big step. It's a big process of doing. You have to add it to the milk, and then you keep it aside for about half an hour, and then you give the milk to the child. So this is a breast milk thing. So the best is to give the hind milk. So I think Dr. Shankaran is talking about the lactase enzyme, which is now available commercially. We do use it for the secondary lactose intolerance. Any other questions regarding probiotics, sir?
Yeah. Dr. Shankar Kather is asking Resicadrotil role apart from the secretory diarrhea, especially useful in earlier administration in and AWD.
So you tell him that
Acute
we're going to
white
have
diarrhea.
another symposium on AWD, on Resicodactyl.
Okay.
This is probiotics.
Yeah.
So I think we'll
Yeah,
just take the probiotic questions, sir.
Yeah, right. So you can continue, ma'am, now.
So I think if there are no questions on probiotics, I hope we are very clear. We'll go to
There is one question, ma'am. Other than antibiotic-associated diarrhea, any other indication where Lactobacillus rhamnosus GG can be used as per your experience?
Yeah, we are now coming to the other 2 cases. So far we have told you in acute watery diarrhea, you can use mainly viral but not bacterial. We have told you the second reason is an antibiotic-associated diarrhea. Now we are coming to the 5th case where we'll be telling you where we can use in diarrhea. Here is a 6-month-old child admitted with fever, altered sensorium. It's a sick child. It is admitted with meningitis. It's in ICU. It has required ventilator support and it has loose stools. So in addition to the respiratory, in addition to the CNS problem, it has also got diarrhea. Though the diarrhea, there's no blood, it is 8 to 12 per day. It is not easy to manage diarrhea also in a child who's in ICU. So this is called as a nosocomial diarrhea. Next slide. So I would like Dr. Srikanth now to tell me, next slide. Nishant was very clear on what was antibiotic-associated diarrhea. Now, Srikanth, you tell me whether this is nosocomial diarrhea and what is the role of probiotics in nosocomial diarrhea.
Thanks for those questions. So to simplify it, there are 3 types of diarrhea which can develop in an hospitalized child. So one is nosocomial diarrhea. This is similar to healthcare associated. It is one of the healthcare associated infection. So we talk about hospital acquired or healthcare acquired infection. So it is one of that is called nosocomial diarrhea. So the other being antibiotic associated diarrhea, which has been discussed. And third is Clostridium difficile diarrhea. The etiological agents are all different. So the management option is somewhat different. But coming to the general measures, so for nosocomial diarrhea also, so there is a role of Lactobacillus rhamnosus GG. Strong evidence with appropriate dose, yes, it helps in curing from this condition along with other appropriate antibiotics. So here once again we have to figure out what is the exact etiological agent with appropriate tests, and child may be having a systemic infection along with the diarrhea because of the same pathogenic organism. So that has to be taken care, and parallelly Lactobacillus rhamnosus GG helps, and based on the systematic review from Hania group, it helps in treatment. And there is no role for Lactobacillus reuteri 17938, that organism that should not be considered here.
So I think specifically they have been comparing these two because at the same time Lactobacillus reuteri was introduced into the market, but it has a specific role which we will not be covering. We know where it is being used. It can be used in infantile colic. It is being used in functional abdominal pain, but it is not. So again and again, we are stressing to the participants that when you give a probiotic, remember it is strain dependent and dose dependent. Very important. You can't use any probiotic for any condition. They are useful. Next slide. Next slide. So in nosocomial, I think Dr. Srikanth has stressed that it is used only in children staying longer in hospital. I think that's what you wanted to say. So this is the last case scenario. Here it is a 10-year-old boy. It is a bigger child, older child, but you know the diarrhea is more in the mornings. He is unable to attend school, but no loss of weight, no fever, no nocturnal disturbance. That means there is no red flag sign, Nishant. Child plays badminton, learns dancing. He's an active child, but in the morning he has to frequently visit the restroom. Next slide. So what is this? So most likely this must be irritable bowel syndrome type D because there are no red flag signs, no weight loss, no blood in the stool. Next slide. So what is the cause for this morning? What's the probable cause of this morning diarrhea? Do probiotics play a role here? So this seems to be like a functional GI disorder. Nishant, what do you think?
Yes, ma'am. This is a functional GI disorder where there is no affection of the growth of the child. His day-to-day effects, lifestyle is not affected. And this is in fact IBS. And when we look at the role of probiotics and IBS, it's one of those conditions where, like we have been talking about, single strain specific, disease specific role. Herein, there are guidelines for the use of a combination of strains, like 8 different strains of probiotic have been combined to form a probiotic named VSL3, which has been studied in these children with IBS and found to be useful. In fact, I was a part of this study and one of the persons who were recruiting children for this study. And it was found that this was a double-blind placebo-controlled trial where VSL3 was used and a placebo was used for 6 weeks with controls every 2 weeks. And there was a washout period of 2 weeks between each patient. And it was found that VSL3 was significantly superior to in the achievement of the relief of subjective assessment of the relief of symptoms when compared to the placebo. Although placebo was effective in some of the parameters, in as many as half the patients, but VSL3 was found to be safe and more effective than placebo in ameliorating the symptoms, in improving the quality of life of these children with IBS. So this is one of the other indications where probiotics do find their usefulness. And quite characteristically, the probiotic used is a combination of various strains of 8 different strains of bacteria. It's not a single strain probiotic.
Next slide. So I think for FGID, there may be a role, but again, we do not know how long to give because FGID is not a time-bound problem. No, Nishant, it will keep going. So I think it is very difficult for us, or maybe at some point of time we can use the lactobacillus, but more or less it will be a lot of, we realize it's a biopsychosocial problem rather than just, it's just not the microbiome. The microbiome definitely does some problem, but it's not only due to that. So can I sum it up saying that probiotics are useful in infectious diarrhea, in treatment and prevention, antibiotic-associated diarrhea only for prevention, nosocomial diarrhea, yes, some little bit of irritable bowel syndrome, no role in CMPA, transient lactose intolerance. And of all the probiotics which we have been discussing, I think Lactobacillus GG, the rhamnosus has been found to be the most effective. And I think we should congratulate Mr. Vijay and Mr. Datta and Dr. Ashwin and Britain Pharmaceuticals for introducing Lactobacillus rhamnosus GG and not bringing something else. So it was easier for us also to talk because we are talking about a probiotic which has been found to be useful. It's not like we are just talking something which is in the book and not which is available. It is now available to us. So I think it's very good. Next slide. Next slide. So the safety, I think everyone is worried. After all, you're giving live microorganisms inside. Are they safe? See, we are only giving microorganisms which are already there. So you have to be careful what you're using, and we know that there are some which we didn't go through it. It's called the ABC of probiotic. You should know what they are. They should be living. They should not produce other things. And so these are generally safe in children. That is what it was found. But in an immunocompromised child, be a little careful when you're giving, especially when they have indwelling central venous catheters. Bacteremia and fungisemia have been reported. There have been reports, especially in babies with congenital heart disease on catheters. So production of lactase by these organisms have also been reported, but it is controversial. So generally, probiotics are safe, but we should know when we are giving, how long we are giving, what you are giving, and before we start giving. So it's no use giving fungal yeast when there is already a fungal diarrhea. So don't go and give something when a child has some fungal diarrhea. Don't give another probiotic. Be very careful, especially when you give it in a short bowel syndrome also. Be careful because suddenly you may have more of fungisemia. Next slide. So I think we'll sum up saying that probiotics do play a beneficial role in some diarrheal disease, re-stress, infectious diarrhea, especially the viral diarrheas, the acute watery diarrheas. Definitely it seems to help. Antibiotic-associated diarrhea in prevention, in nosocomial diarrhea, yes. It also plays an important role in IBS diarrhea. Efficacy is strain-specific, dose-dependent, and I think we'll have more and more of these at now webinar, later seminars on what, when, and how of probiotics. And we need more designs, well-designed studies, especially in India. And it is ideal probably to introduce probiotics as a functional food. And I would like to thank my panelists for that wonderful way they led you through the 6 cases. And I thank all the participants, and once again thank Brinton for giving us this opportunity to talk about probiotics. It was a very good experience for us, and we also went through many papers to give you this lesson.
Madam, we have the 2 questions. One is Dr. Shilpa Pusute. Why not to give with every time we give antibiotic? Why we can't use the probiotics whenever we use the antibiotic?
I think Nishant, you'd like to take that question?
Well, that's a very good question. Why can't we give it every time?
Yes.
You see, when we look, not every child or adult is going to have antibiotic associated diarrhea. So the first question will definitely be, are we going for an overkill? Second thing is, are we actually going to help the child? Because that should be the first and the foremost thing. We don't have as of now studies for use of probiotics in each and every candidate which have been put through antibiotic use. And for most antibiotic dosage and duration, which is usually not more than 5 to 7 days, we do not find that any diarrhea occurs. So the use would definitely be an overkill. But yes, it's a thought, and it can be used, but with its own caveat. I think we don't have any studies per se to promote its use in each and every case of antibiotic being prescribed, especially when we know that most of these antibiotics are not prescribed for more than 5 to 7 days.
Yeah, I think it's very, very important. That question was good, but one is, I think there was one paper earlier saying that the number needed to treat to prevent is also quite high. That means you have to give 6 individual children to prevent 1 antibiotic associated diarrhea. So it's that is also very important. Because of that, they have said narrow it down. And I think Nishant is very clear. He says use it when a child has already had antibiotic associated diarrhea. Use it in hospitalized children. Use it when you think you have to give it for a longer time. And there are some antibiotics you're very sure it will produce diarrhea, like amoxicillin. I think that would be the best way to take it, a malnourished child, rather than giving it for all children. I think you have to look at the number needed to treat, which is not very thing. And I think, like he said, all children don't get antibiotic-associated diarrhea. Next slide. Next question.
Ma'am, one more question from Dr. Sangeeta Garg. Any role for combination of probiotics that is available in the market?
See, the studies have not been done like that, except for that BSL-3, where it is a very balanced study of 8 strains, 8 things. They had Streptococcus, Lactobacillus, and a thing, and they did it mainly for our FGID, especially in IBD. They had done a lot of studies in ulcerative colitis. Otherwise, I think combining 2 antibiotics studies have not been done, but you know, they have taken Hania study, and they have said, okay, since Saccharomyces works as well as LGG works, why not put both? And it's now available in the market. But none of the studies have done showing adding it, whether a beneficial effect is coming. See, when you give more and more food problems to the child, the cost is going to increase.
And
Nishant, do you have anything regarding this antibiotic combination, this probiotic combination?
Yeah, I just like to mention that the probiotics are genus strain specific and disease specific and dose specific and the duration specific. All these things are specific, and only then can a probiotic can be used as a drug, because we have to understand that we are giving live microorganisms to an individual. And these we do not, unless until we have studies to show that they interact in a conducive positive way, they should not be ideally combined. So most of the studies which are used to help promulgate the guidelines are on isolated strains.
Yeah, I think only isolated. We don't have, except for that BSL3, which I think Srikanth was also mentioning. No, Srikanth, about the BSL3.
Okay. Ma'am, one more question. Can we use probiotics in the children with the isolated IgA deficiency?
IgA, you want to answer, Srikanth, or shall I take it up? See, isolated IgA deficiency, they present with recurrent diarrhea as one, mainly giardiasis, recurrent giardia infection. They also present with recurrent respiratory infections. Giving a probiotic, assuming that IgA, the child does not have IgA, it is a problem by birth, it is an immunoglobulin D deficiency. By giving a probiotic, your IgA will not come up, and here we are not only talking about the secretory. So there is a problem. So probiotics, how long to give? Though there are some studies saying giving colostrum, all the ones which contain colostrum will increase, but I believe it will never increase, because the problems come little later in life. Many of them we have seen even in adolescent, we picked up selective IgA deficiency. They don't present even in the early infancy, except when it's very severe, when they come with respiratory infection. So probiotics need not be given for these IgA deficiency. You have to give IV, IG for these individuals, and it's so costly. If probiotics can give IgA, we don't have to spend so much. You have to give IV, IG here.
And ma'am, Dr. Rimjim Srivastava have asked, can we issue some recommendation for not using combination probiotics?
I think Nishant has spoken very clearly about that. No, Nishant, that's what you said. Studies have not been done.
Yeah, I think Rimjim wants, I think, a recommendation from probably ISPGAN society as such, so that such use is not promulgated.
But ISPGAN should do individual studies, no, with individual.
Exactly. We need more studies. We need Indian studies, and then probably
Indian studies.
Definitely.
And then one last question. They are the nutraceuticals with the probiotics. So what's your take on that?
Nutraceuticals with probiotics. I think leave the probiotics as probiotics, and then you give that separately. I think only in our country they will add everything. That is why finally probiotics will become a functional food, and we don't have to have all these discussions. It will be available in the supermarket, and everything will end up like that. That is what has happened in US, and therefore you don't get any study from USA, because they have taken it as a functional food. No studies on probiotics from United States, because it is now available for them. I think it will become like that once we start putting nutraceuticals, everything in that.
That's all, ma'am. Thank you very much. At Brinton, we are very thankful for our eminent speakers, Dr. Malati, Dr. Nishant, and Dr. Shrikant. I am very sure today's session will add a lot of value to clinical practice of pediatrician in country. At Brinton, it is our constant endeavor to keep pace with the changing trends in the field of pediatrics by innovative products and the dissemination of the knowledge. And thank you very much once again for all the doctors who have spared their valuable time for today's session. Thank you very much, Madam, Dr. Nishant, Dr. Shrikant, and all our audiences. Thank you so much.
Thank you, Dr. Nishant and Dr. Srikanth. It was very nice, and thank you, Aarti, for the perfect zooming and
Thank you,
sending
ma'am.
the slides and the right time. I think it went off very well. It was a smooth flow. Thank you so much. Bye.
Thank you, ma'am. Thank you so much.
Thank you, sir. Thank
Thank
you.
you very much.
Thank you, sir.
Thank you.
Thank you, Srikanth. Thank you, Mr.
Thank
Vijay.
you.
Thank you, everyone.
Thank you, ma'am.